The past is a place to learn something. It is not a place to live in. So our next topic and next speaker, Dr. Jignesh Usdadiya, is going to talk on the importance of past history. So, Dr.
Good evening, good night. Thank you, APR, for inviting me. And I will be discussing one short case. Everything lies in the past history. So I will be discussing one short case. This patient I have seen in March, around 13th March. So she is 15-year-old girl, and she presented with history of right groin pain. Groin is mostly located anteriorly, so like pain in the hip joint, and with history of difficulty in sitting cross-legged or cross-leg position, and the history was for 1.5 months. At the same time, she also revealed that she had history of lower back pain on the right side, same side, but it resolved with treatment, and it was not present. And there was history of right ankle pain. According to father and patient, the swelling was there and there was difficulty in walking when ankle joint pain was there. But that also subsided within 1 week with treatment. So, on examination, her hip joint was non-tender, other joints were not involved. Faber is flexion, abduction, and external rotation. That examines the two joints, hip joint if pain is occurring anteriorly, and sacroiliac joint if pain is occurring on posterior side. And she was not able to perform the Faber, that is flexion, abduction, and external rotation on the right side. And she was complaining of groin pain, not the back pain. And left side, it was examination was normal. At the presentation, her ankle joint was non-tender and non-swollen. T is for tenderness, S4 is for swelling. Other joints were normal, and spine was normal. Other system, respiratory and systemic examination was normal. On gait examination, there was mild limping on the right side. And she already came with this MRI report. MRI report was already done 2 days back, and it was showing right side active sacroiliitis. There was hyperintense signal, and it was limited to sacroiliac joint only. There was inflammation was not going outside the joints, and on reporting it was written as early changes of left side sacroiliitis. But on actual imaging, there was not significant stir signal because radiologically it should be very significant to level as active sacroiliitis. And hip joints are normal. So complaint was more of hip joint, but clinically or radiologically it is of more of sacroiliitis. So this is a case of unilateral sacroiliitis. History was almost of 1.5 months. And unilateral sacroiliitis, there are many differential diagnoses. Mostly, we usually think inflammatory. Inflammatory, in early stages, they can present with unilateral inflammation, then it goes to bilateral. And some disease may remain unilateral, like psoriatic arthritis, enteropathic arthritis in IBD, Crohn's or ulcerative colitis. It may remain unilateral. Gout can have unilateral or bilateral. Spondyloarthritis usually have, that is, we call ankylosing spondylitis, usually start with unilateral and progress to bilateral. Reactive arthritis can start with unilateral sacroiliitis. Infection. In unilateral sacroiliitis, we always have to rule out infection. That depends on the two things. Systemic symptoms are present at the time of presentation, before the presentation. That is the main thing. And another thing is response to treatment. If it is inflammatory sacroiliitis, it will respond very good to NSAID. And if it is infective, it may not respond. And third and last thing is malignancy or metastasis. So during relevation of past history, she had history of headache with diplopia specifically in horizontal gaze. And it was present for 2 weeks, and that history was long gone back to December 2024, that is 2.5 months back. And that time she was evaluated by ophthalmologist because headache and some vision problem, we usually think it is related to eyes. And before that also, she had a history of long prodrome symptom where she has anorexia, probably low grade fever because she was studying in some hostel and she was 10th standard student. So it was around before the exam. So they have taken local treatment and it lasted almost for 1 to 1.5 months. And she had history of weight loss. And after that, she had these symptoms of headache and everything. And when she consulted ophthalmologist after the symptoms of headache, it was diagnosed with bilateral eye papilledema with bilateral 6th cranial nerve palsy. So ophthalmologist directly referred for imaging and MRI or with MRvinography was done. And it was more of suggestive idiopathic intracranial hypertension. Brain was screened but not in detail, but there was no any focal brain lesions were there. So with this idiopathic intracranial hypertension, patients refer to neurosurgeon. So that is the main dilemma. So in this case scenario, there are two special surgeons are involved. If instead of surgeon, if physician was involved, she was diagnosed early. So neurosurgeon did CSF and CSF pressure. CSF pressure was high. Though CSF routine micro looks normal, but total count was 30 and glucose at 90%. So she was investigated and her ANA was done and TSH was done. Other routine CBC and SGPT creatinine was done, they were normal. Trace proteinuria was there, trace or 1+, that's why ANA was sent and ANA was negative. And TSH was normal. And she was started on acetazolamide and she had partial response. She had recovery in the headache, but she is still complaining of intermittent headache. And there was no past history of headache previously, like my children can have migraine, but she was denying such history. And after the headache part completed, she had history of some abdominal pain, nausea, anorexia. And abdominal pain was around umbilicus and epigastrium, and she went to gastrosurgeon. So gastrosurgeon did all this report in view of joint pain and everything. Reports of RF and CCP, they were normal. Routine CBC was normal, but slight thrombocytosis is there. And there was slight hyperbilirubinemia was there. These reports were done on February, almost 1 month before she visited to me. And SGPT was very high, 1196, and SGPOT is elevated, 981. GGT was elevated, ALP was also elevated. Urine was showing 4 to 6 per cell and protein was stressed. Her ESR was 41 and CRP was 11.79. B12 and vitamin D just they were done, they were normal. USG, it was more of suggestive of hepatitis or some infection, viral or something. And it was mild hepatomegaly with mildly reactive gallbladder wall thickening and few reactive periportal nodes. So this case now summarized is a one unilateral sacroiliitis, right side, idiopathic intracranial hypertension, cause we'll find out, and she had hepatitis with prodrome of long back fever or anorexia. So most likely it is some infection. So we investigated when on the visit. CBC was almost normal, creatinine, urine routine was normal, there was no icterus, bilirubin was normal, but still transaminitis was there. And ALT was more than AST. GGT slightly elevated, ALP as per age was normal, and other secondary immunosuppression, she was not diabetic and viral markers were negative. Even CRP was normal when she presented to us. her Brucella antibody was sent because in such cases, either we suspect because of prolonged symptom, either TB or brucellosis comes in mind. If it is very sudden, severe, acute, then we have to think other bacterial infection also. So IgM was negative, IgG was strongly positive, and slide agglutination was strongly positive. Usually in endemic area, it says 1:320 is positive. Non-endemic, when it is 1:160 is significantly positive. And because she was complaining of right hip and high area pain, I just evaluated by USG because MRI was done 2 days, 3 days back only, but it was normal. Because sometimes this patient can have focal myositis along with infection. So that's why we did this. And taken a neurophysician opinion. And he examined again, and papilledema was still there. And he suggested that when she had it, it is likely asymptomatic meningitis like picture because her CSF routine macro was showing 30 cells. That is still high. So most likely it is a meningitis that is causing the raised intracranial hypertension. Aseptic or viral or bacterial, whatever it is, and most likely this is possible chronic brucellosis. Word possible is because you cannot prove by serology. This diagnosis only can be proven by with treatment and clinical response. And brucellosis, ideally, if it is found in blood culture, then only we can label as a definite brucellosis. And positivity of blood culture is 50 to 70%. Before starting treatment, we already sent blood culture also, and we have to specially advise laboratory that please look for brucellosis. So they incubate for at least 7 to 14 days. And usually it takes longer. If BACTEC method is used, we can isolate in 7 days. So treatment, because of mainly CNS involvement was there, the ceftriaxone was needed. If CNS involvement is not there, then we can give aminoglycoside. Recommended is streptomycin, but it is toxic, and mostly patient refuses for intramuscular injection. So omegacin or gentamicin is good choice. Omegacin is preferred. I prefer because you can give once a daily dose, 15 mg per kg. And because CNS involvement was there, the parenteral antibiotics were given for 4 weeks. Otherwise, we can give for 2 weeks if it is only sacroiliitis and hepatitis and other system is not involved. And along with this, we have to start doxycycline, 100 milligram BD maximum dose for adults. Children, it is 4 mg per kg in 2 divided doses, maximum is 100 BD. And rifampicin, 15 mg per kg for 4 to 6 weeks. The first follow-up was kept after 15 days, and she came walking without any pain, and that is the response. If patient responds after 2 weeks of parenteral antibiotics with unilateral sacroiliitis, then it is a good response. And musculoskeletal examination, there was no tender solangoid. She was able to perform Faber test, and there was no pain, so bilateral Faber tests were negative. And reports repeated after 15 days, SGBT, SGOT completely become normal. Blood culture, 14 days incubation they kept, it was not showing any growth. And the further plan was to complete 4 weeks parenteral. Still now she has completed 4 weeks of parenteral and also completed, I think, 2 months of oral antibiotics. To continue it for 4 to 6 months, she is currently under follow-up of neurophysician. So in this case scenario, take-home message is when there is some multi-system involvement or preceding history of systemic symptoms with unilateral sacroiliitis, please think of 3 diagnoses. One is infection, second is IBD, and third is metastasis. Thank you.